Okay, well, I know people are still logging on, but let me get started. I am Dr. Kathy Troisi. I am a professor here at UT Health School of Public Health in Houston, and also involved with the Texas Epidemic Public Health Institute. So welcome to our January Grand Rounds. Our speaker today is Dr. Ali Khan. He is the Dean of the University of Nebraska Medical Center College of Public Health, and he is also former Assistant Surgeon General. He brings decades of experience in emerging infectious diseases, bioterrorism, and global health security. He founded the Public Health Matters blog and has been personally engaged in guinea worm and polio eradication efforts. While directing global infectious disease activities, he designed the lab component of the CDC's Field Epi and Training Program, and he also helped design and implement the CDC component of the $1.2 billion five-year President's Malaria Initiative. He co-founded a novel center at the CDC to champion a One Health strategy to ensure health security from a myriad of zoonotic, vector-borne, and foodborne infectious diseases. Most recently, he has focused on better integration of public health and healthcare for disease prevention, reducing health inequities, and the social determinants of health. And I have to add that he and I are co-editors on APHA's Center Control of Communicable Diseases Manual. As you can see, he has a wealth of experience. He's going to be telling us about hemorrhagic fevers today. But first, I just want to tell those of you who may not be familiar with TEPHI a little bit about our mission. We are a state agency committed to keeping Texans safe and the economy strong so that we can respond to future infectious disease outbreaks, which unfortunately there will be. Our next slide, please. We collaborate with a lot of different agencies, governmental, nonprofit, in the state, national, business, academic institution, community organizations. So we have a wide-reaching stakeholders that we work with. Next slide. So I want to tell you some of the other things we offer. We have a pandemic preparedness and response certificate program. These are totally online, asynchronous, free to Texas residents. They are comprised of 4 courses: an EPI course, infectious disease surveillance course, and then a public health emergency preparedness response, and then a tabletop capstone activity. You can get CE credits for that in a variety of disciplines. And as I mentioned, no cost for Texas residents. You can see there's a QR code there. We'll put that in the chat, but you can also go to our website and I will put that in the chat as well. The next slide, please. We also offer some mini courses, 1 to 3 hours, again, asynchronous, online, free to Texas residents, and CE credits available for these as well. So if you're interested in one of these, you can take them. They're standalone. They're not linked to the certificate courses. Next slide. So lots of ways to connect with us, and these are some shortened web addresses, but Courtney just put the TEPHI website in the chat, so you can find all this information there. And then I think the next slide is just some housekeeping. Yes, if you want closed captioning, you can click live transcript, use the chat function for questions. We'll do those at the end. There is a survey at the end that please fill out. If you have suggestions for other topics you'd like to see covered, please let us know. This webinar is being recorded. In about a week, we'll send it out to everybody who's registered, and you can watch it on our YouTube channel. And I think that's it for my slides. Yes, and I already gave you Dr. Khan's impressive bio, so go ahead and take it away. Tell us about hemorrhagic fevers.
Thank you, Dr. Troisi. It's very, very generous of you to invite me to come and give Grand Rounds for TEPHI. I'm going to chat a little bit about viral hemorrhagic fevers today, and present sort of the general characteristics of these conditions, and then discuss a little bit more of why they continue to be emerging threats for us, not just globally, but here at home. I'd like to actually start with acknowledgments. So let me acknowledge Dr. David Brett Major. I decided to highlight his investigation of Marburg on behalf of the university, and I'll be chatting with that. I'll be discussing that a little later. Dr. John Lowe, who's director of our Center for Global Health Security, responsible for actually domestic and international responses on behalf of our university, and also chair of our Department of Occupational Health and Safety. And finally, Ms. Alexander Todd, a graduate of ours who's responsible for putting these great slides together. So I want to make sure I acknowledge them for the opportunity and the ability to give this talk today. So I have to say, Kathy, you were pretty prescient. So today's news is about a suspected Marburg outbreak in northern Tanzania. 11 cases, I believe 8 deaths, including cases amongst healthcare workers, which is always very suspicious for a viral hemorrhagic fever. The symptoms are the disease itself. So it sounds like a viral hemorrhagic fever, but healthcare workers and a high case fatality is really the typical triad we see when we think about viral hemorrhagic fever. So hopefully in the next couple of days, we'll get a clear diagnosis of what this disease is and some measures in place to treat it. So let me take you all the way from Tanzania to right here in the United States in Iowa. And so basically, for all of you in the public health world, this is a very bad day when the lab calls you and tells you that somebody who's in your hospital was infected with a viral hemorrhagic fever. In this case, in October of this year in Iowa, unfortunate gentleman who had traveled abroad came back and died with Lassa fever. Now, the initial reports were no reason to worry. This gentleman was isolated in a containment facility in his hospital with all appropriate precautions when he died. And so there should be no risk of a secondary person-to-person transmission, which is a concern with Lassa fever. We've had, I think this was our 9th importation of Lassa fever in the United States since 1969. The last one was 2015, I believe, was the last time we saw Lassa in the US. And Lassa is one that always worries us because we do know it's associated with not just person-to-person transmission, but it's associated with large nosocomial outbreaks in healthcare settings. So if you read the newspaper, you're feeling, okay, thank gosh, this gentleman was in a high containment facility, he was fine. Well, what you don't read below the surface is that he actually went through, this was the 3rd hospital he was in since he was sick. And then it doesn't take very long to figure out that there were a whole lot of contacts in this process who need to be monitored to make sure that none of them became ill. And we were fortunate here at the university to work with our great colleagues in the Iowa State Health Department, also in the University of Iowa Health System, and with CDC to provide support for the initial diagnosis. We are a diagnostic lab here for viral hemorrhagic fevers, and then for the support for the contact tracing. Now, this story should be very familiar to all of you who are part of TEPHI because you may remember your own instance, unfortunately, tragically, with an Ebola case in the United States. Again, unrecognized on entry into the US, unrecognized on initial development of signs and symptoms of a non-specific viral fever-like illness. And that individual did lead to, tragically, he passed away, but did infect 2 additional healthcare workers. And so this is the scenario that always concerns us. We were lucky in Lassa fever that time, but not so lucky in Ebola that went unrecognized that we did get secondary transmission within a healthcare setting. And this is why this disease is always, these diseases are always at the top of our list for concern of entry into the United States. So let me step back now Hopefully you recognize why we care. I'm sure most of you already knew why we cared, but I wanted to sort of make the point that this is relevant and relevant today, and relevant all the time in the work that we do as public health practitioners, and for all of those of you who are clinicians on this call. So viral hemorrhagic fever. So let me get rid of this up front and discuss this. So viral, yes, they're all viral, and they can cause hemorrhagic fever. They do not necessarily cause hemorrhagic fever. For the most part, these individuals, the biggest issue is that their blood vessels and their blood system doesn't do very well, and they tend to sort of drop their blood pressure when they get severely ill and potentially die. But they may bleed, and many of them do bleed. And if they do have blood loss, it's often due to a combination of things. It's not one specific condition. It's a mix of direct infection of the blood vessels, the immune response to that infection, impaired clotting, platelets don't work very well, maybe liver damage that's reducing clotting factor production. So there's a lot of different reasons why these patients might bleed, but it is often the trigger that you have a viral hemorrhagic fever is when you do see somebody who has a fever and a hemorrhage that's unexplained in nature. But do want to make the point that although the movies love to show you people bleeding out from every orifice, that's just not the reality of the situation. This is a little, now that I look at it, this is a little bit of a complicated slide, but these are the major sort of families that are responsible for viral hemorrhagic fevers, all in one slide to try to make it a little bit easier. I guess it's a complicated slide, but it does make things a little bit easier to understand. So let me take you to the center. So these are the filoviruses, the filoviridae family. These are your Ebola virus and Marburg viruses. This is where these come from. And I just talked about the Marburg, suspected Marburg outbreak in Tanzania. I'm going to skip Hanipa for a minute. The flaviviruses are your yellow fever, dengue, etc. So those are your flaviviruses that cause those hemorrhagic fevers. And then the other big set of families that cause hemorrhagic fever are the Crimean hemorrhagic fever, the Neiroviridae. Now, of all the viruses that cause these infections, this is the bloodiest of the lot. So when you're thinking about bleeding from every orifice, what you're probably thinking is Crimean Congo hemorrhagic fever. And this is actually sort of a shout-out diagnosis on exams, which is typically a shepherd comes in with a bleeding, suspected bleeding ulcer, goes to the operating room, and within 3 to 5 days, a number of people in the operating room are also infected and quickly going to die. That's going to be Congo-Crimean hemorrhagic fever, right? That's just a typical history of somebody in the rural area got a tick bite, bleeding from all over, suspicion of a bleeding ulcer or bleeding esophageal blood vessels, goes to the OR, infects a whole lot of other people. Rift Valley fever, we often see this in conjunction with malaria, large malaria outbreaks, because the eggs dry out, hang out for a long time, and with lots of rain, they pop up, and all of a sudden, you've got your Rift Valley fever. Hantaviruses, you're in Texas, you know we have our own New World hantavirus here, Sinomre, etc., not associated with hemorrhage, but the Old World hantaviruses, think about Korean hemorrhagic fever. Those are associated with hemorrhage. And of those, okay, and those are associated with hemorrhage. And then finally, Lassa, Old World arenavirus, associated with hemorrhage. And then the New World viruses, there's a number of New World viruses also. So these are the typical families that are considered viral hemorrhagic fever families. I didn't mention the Hanipas because it depends on your classification of viral hemorrhagic fever. Most Hanipa viruses, people usually think of them as encephalitic viruses, but they can bleed. They also share many common characteristics of these viruses, so people include them in this group, and I tend to include them in this group also because of those many shared common characteristics. And let me chat about some of those common characteristics. Oh, big red dots. Big red dots are the ones that are transmitted from person to person. So these are of particular concern because these are the ones that will lead to secondary transmission within a household, within a hospital, within a community, or within a lab. So these are the ones that we were, so obviously Ebola is here, CCHF is here, Lassa is here. Now, the best way I have found, so I had to be very careful about an hour talk because this is 30 years of my life I'm trying to distill in an hour. So the best way I have always thought about thinking about this group of viruses, despite the fact that they fall within various different families, is that uh, the epi is truly defined by their vector and host distributions. So these are all zoonoses. Each and every one of these is a zoonoses. And if you can figure out what harbors the virus and the behavior of that virus and more importantly, the behavior of that vector or that host in relationship to people, you will get a really good sense of what the epidemiology is going to look like to you for that disease. So is that host, be it a mouse or be it a bat or etc., is it widely distributed? Is it not so widely distributed? Is it distributed close to humans? Is it not distributed close to humans? So that really does help you define what to expect about the epidemiology. And it also explains why we have so much difficulty sort of doing prediction work with these viruses, because it's so variable about in the nature of that interaction back with the host, and then obviously within the host, what the level of virus or infection may be, which is cyclical and seasonal in nature. But it's all about the host. And based on that, you can then say, okay, where are you likely to see viral hemorrhagic fevers? Here's a global map that lays this out in terms of North America, obviously HPS, if you consider that a viral hemorrhagic fever. South America would be the arenaviridase and obviously the flaviviruses that occur there, and then the spectrum of them that occur throughout Europe, Africa, and Asia. Now, this is at a broad level. Again, as I said, if you think about the epidemiologies of these diseases, it's about vector distribution, right? And so you can actually do detailed maps of saying, okay, where's the bat distribution of this? Where are the rodents? Where are the ticks? And you can map where the vector and host lie, and then that can help suggest to you where a disease would likely lie. And so it's not a coincidence that when you look at where your Ebola outbreaks or Marburg or CCHF or Lassa outbreaks, they're where the vector happens to be, right? So if Lassa all of a sudden showed up in Tanzania, you'd go, that doesn't make sense. Is this an imported case or what's going on? Or is there a new reservoir host that we don't know about? But if you happen to live in Nigeria, you should be expecting Lassa because that's where mastomes, these multimammate rodents, sort of hang out. So again, think vector to give you a sense of what to expect and what in terms of the broader epidemiology of the disease. As you think about sort of distribution and infection and cycles and timing, seasonality, et cetera, et cetera. All right, so most of these diseases, well, all of these diseases, right? The initial route and often the primary route is that contact with the infected animal host or the affected animal carcass. If you come across a dead animal and decide to eat it or something like that, that's infected, the bite of a tick or mosquito, right? So this is the initial route of transmission, and as I said, often the primary route of transmission. However, for a subset of the diseases, right, the ones that I marked with that red star, I guess, a couple of slides back, for those you need to worry about then secondary transmission, right, which may not just be a one-off, but maybe a large outbreak that can occur with these diseases, as we've seen for many. So close contact with an infected person's body fluids. For most of these, this is how they're transmitted. These are just two examples. Some are associated with also associated with vertical transmission to babies. The big concern and what often is a source of expansion of these diseases that are communicable or transmissible from person to person is often nosocomial disease. So many of these diseases, let's see the ones I see there. Okay, so the ones I see there, you tend to be more infectious the later you are in your illness, and that's also when you're most likely to be hospitalized, and that's why you see these explosive nosocomial outbreaks that occur with these diseases as people get hospitalized. And all of these are also often have been associated with laboratory infections. So the virus itself, as a small particle aerosol, can get you infected, which is why these all spend their time living in biosafety 4 laboratories. So that sort of gives you a sense of that connection with viral hemorrhagic fevers and why do they need to be, not all of them, but many of them in biosafety level 4 labs. Was because they cause laboratory infections, and often it's a severe illness for which therapy may not be available. And finally, we know for many of these diseases, if you get infected, you may harbor long-term reservoir within your semen and then infect other people weeks to months later. So we do know there's sexual transmission with these viruses also. This is a little bit of a complicated slide, but I think it makes the point of how to think about these diseases and their transmission patterns and how you use that to try to think about prevention strategies for these diseases and prediction strategies, prevention strategies for these diseases. There's sort of an enzootic cycle of, this one is specifically, the ticks is probably CCHF. This is CCHF. So the ticks doing what ticks do, infecting animals, they're doing what they're doing. And occasionally that tick will infect a person, and that person then will get severe illness and can get severe illness and potentially die. But that person can also transmit disease to somebody else, here labeled nosocomial transmission. And so that's how you sort of get this propagation of disease, because then it's just, you don't need the zoonotic cycle anymore. It's just people infecting people at that point. And with the people infecting people, you can see sexual and vertical transmission that happens also. So again, complicated slide, but makes the point about all those different modes of transmission that we can see with these diseases. The symptoms are also pretty typical, and to be very honest with you, very non-specific. So it's hard to criticize a clinician, even in a highly developed country, for not recognizing somebody who comes in with a fever, headache, muscle aches, exhaustion, and nausea. And I'm sorry, Lassa is not going to be the first thing that comes to my mind, and I think about this all the time for somebody who walks in the ER with this symptom set. Now, obviously, we get travel histories and stuff like that to try to help us, but it's the early symptoms are not very helpful. And the same thing is true, not just here. I mean, think if you're in Africa. I mean, if somebody walks in with that, I'm thinking, well, there's your, if I happen to be in Tanzania, I'm thinking, okay, well, I've got malaria, I've got dysentery. What else are the things that are more common diseases that you're likely to have besides one of these more exotic conditions? And then it's later when they start having sort of other organ systems that are affected, including potentially bleeding, that you think, okay, this may well be a viral hemorrhagic fever. And that would be a good day when you pick it up then before you potentially get infected. And then everybody goes, oh, it's causing nosocomial transmission. These diseases vary in severity, so it's not a good way to sort of it's you can't sort of lump them all together that way. But they do vary in severity. Some highly fatal, not so fatal. And we've over the years have recognized that actually good supportive care can markedly decrease case fatality in these illnesses. But yes, they can be fatal. They can damage blood vessels and cause dropping in your blood pressure and bleeding. So that said, let me give you a quick snapshot of the highlights for some of these diseases. All of these slides will be made available to you. I worked at CDC for a very long time, and now I work at a university, and everything I do should be open source and available to you. So let's start with and I'm going to start with Lassa, honestly, because this is the one that causes the most disease globally. Now, the second most disease globally of these conditions, and the one that really I hope we will make a lot of progress on getting a vaccine for. It's endemic in West Africa. It's associated with that cute little rodent that you see on your slide. But it's what does it say? 300 to 500,000 cases annually, 5,000 deaths. And because this disease is so widespread in West Africa, especially Nigeria, and travel patterns, this is the disease that's most commonly exported to non-endemic countries. So a typical story would be, and you're aware of these stories, obviously, from COVID days, that somebody went home to Nigeria because of a family death. In the midst of this Lassa fever outbreak, they get infected there. They come back to the U.S. and or Europe, and they bring the disease with them. The majority of these cases are asymptomatic, and these are annual outbreaks that occur with Lassa fever all the time. Okay. The second one is Marburg fever, and I'm going to lump Ebola virus here because clinically they're the same for the most part, although virologically they're different. These are fruit bats, so hello, cute fruit bat in the corner. That's how the disease is spread by these bats. Outbreaks recorded in multiple countries in Africa. And the last recorded outbreak was just recently in Rwanda. I'll talk about that briefly. And potentially now, as I just said, a new outbreak in Tanzania. CCHF, I put this on the list to discuss for a number of reasons. One is it's tick-borne. It's also the most widely spread of the hemorrhagic fevers through Africa, Europe, and Asia. Can be very severe. Does cause large nosocomial outbreaks, characteristically causes nosocomial outbreaks, and nosocomial outbreaks. Oh, and this is the one that I said that bleeds. So when in your mind you're thinking about that movie with somebody bleeding out, what you're thinking of, you don't know it, but what you're thinking about is Congo-Crimean hemorrhagic fever. So the next time you have to play Jeopardy or something, CCHF. This is the leading cause of arthropod-borne viral disease worldwide, dengue fever. This is out of control, also out of control worldwide. Fortunately, if it's detected early, you can really drop case fatality rates down dramatically. But this disease is common in many countries. And what do I have there? 2024, 12 million cases were recorded in just here in the Americas in 2024. So we're in the midst of a large dengue fever outbreak. And you can't talk about dengue fever without talking about yellow fever, which uses the exact same vector for the most part, Aedes aegypti. And this is also increasing worldwide, significant case fatality associated with yellow fever. Also, the reasons for the increase in yellow fever and dengue are a little different. Dengue is all this urbanization and places where mosquitoes can hide that make it very difficult to track. Yellow fever vaccination levels are dropping around yellow fever, and has for both of them vector control programs, and that's what's getting people in trouble with this vector-borne disease. Oh, okay. So those were the highlights of the VHFs I wanted to share with you. The other really, I guess the really nice thing, and I'm allowed to say nice things when I talk about VHFs, is that there's market progress that has happened with therapeutics. And Ebola is a good example. We have an FDA-approved vaccine to prevent one of the viruses that causes Ebola, and we have a monoclonal antibody that's useful. So very encouraging there for Ebola. For Lassa, we have ribavirin, which is pretty effective to use for Lassa fever, and there's some candidate vaccines that are developed, and I think I may have one of them on my upcoming slides. This is the Ebola vaccine tested during an outbreak, pretty effective, 84% effective, and a great example of a global community coming together all the way from the creation of the vaccine to the testing of the vaccine, often in very difficult situations for lots of different reasons. Besides, it's often rural areas with no infrastructure in the midst of an outbreak that you're trying to do good science in, and then subsequently scale up of the vaccine and availability for where it's needed. This makes me, I put this slide in because this just gives me great joy that there's a phase 2 Lassa fever trial currently in place. As I said, this is a disease that does not get as much attention as even Ebola outbreak or a Marburg outbreak, but it is endemic in West Africa, and it would be really great to have a vaccine available for people in West Africa to prevent this disease. So if I want to sum up some of these things, it's really difficult predicting these outbreaks for lots of reasons. They're zoonotic in nature. There's always a potential for a spillover event from the animal to the human. There's limited data on surveillance and infrastructure, unpredictable transmission, et cetera, et cetera. So some of the difficulties with these VHF diseases and potential subsequent outbreaks that makes life interesting. All right, I'm gonna skip to the next step. Oh, okay, this is fun. I'm gonna talk about some of the work that's done. So this is a shameless plug for UNMC and our work domestically and globally on these viral hemorrhagic fevers. But first, I'm gonna tell you what do I do every day. So this is my life. I spent my life preventing this.
The most optimistic projection USAMRIID is willing to make for the spread of the virus is this: 24 hours, 36 hours, 48 hours. The containment procedure must be viewed objectively. Be compassionate, but be compassionate globally. Thank you.
Please. The president's ETA from the East Asia Economic Summit is about 20 hours from now. He wants a recommendation by then from this group. Now, as I understand it, you want to firebomb the town of Cedar Creek, California, population 2,600, with something called a fuel air bomb, the most powerful non-nuclear weapon in our arsenal. The way it works, it explodes, sucks in all available oxygen to the core, vaporizes everything within a mile of ground zero, men, women, children, and one airborne virus. Destruction complete, case closed, crisis over.
So there you go. I've taught a lot of classes. I've taken a lot of classes. Firebombing was never one of our prevention strategies. So there you go. If somebody ever asks you what you do, you go, oh, I prevent people from firebombing you with good public health practice. All right. That was just fun. How could I not show that to you, right? All right, let's find the next one. Back to here. Maybe. Okay. So again, as I said, we run a national center funded by the Department of Health and Human Services, CDC, DOD, some state department to help support domestic preparedness and response for these high hazard pathogens, including Ebola, including these viral hemorrhagic fevers, but includes COVID and a number of other diseases, monkeypox, for example. And so we run a network of biocontainment facilities, research facilities, and do this domestically and internationally. And we work with all of you. We actually have obviously partners in Texas to develop the best science. So if you think about the data that came out around SARS-CoV, contamination and aerosol transmission came out of our biocontainment facility here. If you think about remdesivir for the treatment of COVID-19, we participated in that original clinical trial and getting that together, and some of the original diagnostics came out of this network that includes all of you on this call, as Texas is a big partner in that work. Also, we had the opportunity to put out what we call COVID-19 playbooks. So our view always was, how do we keep society functioning as best as possible? And for us, it was about how do you put the safety, sort of the layered measures, safety measures in place, public health measures in place, so that people can keep facilities open, whether it be higher education, P to 12 correctional facilities. We did a whole up there. We did a whole lot of work in meatpacking plants. So these were national guidelines available. I guess national guidance available for people to keep themselves and their facilities, places of employment safe. Our approach to our international work is always about longitudinal engagement over a long period of time. So we deployed a team for Rwanda for their last Marburg outbreak, but that's not the first time they had seen us. We had done work with them many years in the past, and that leads to strong relationships and the ability to really help support the ministries of health within these countries. Quick snapshot of Ebola. So I know it's hard. If I was in person, I'd be asking questions now. So all of you should say to me, so Ali, if I said to you, Ali, where does Ebola occur? You'd be like, okay, where does a vector occur, right? And yes, okay. So you have that slide on the right of you, right? Which is, this is where the vector is. This is where you would see disease. And on the left is all the places where we've seen disease during the distribution of the vector, and then it gets exported. So this sort of gives you a sense of the outbreaks that have been reported to date, and then where we have seen them in reference to their primary rhizotous bat distribution. And this shows you some of the bat distribution, some of the mines that occur with all these lovely bats you see flying around. So it's pretty easy to understand. What you need is that animal-human interface, right? And so it's easy to see that animal-human interface, whether it's occurring at a cave or a mine. In this case, Marburg's a little bit different. But caves and mines seem to be the thing for Marburg, given the nature of the bats that are served as the reservoir. And so there you go. You're like, okay, well, we actually have the right environment needed to catalyze a spillover event, and that's exactly what happened with an index case patient presenting to the University Teaching Hospital, Chuck. So and very quickly. And you could hopefully have predicted this based on what I told you. Somebody comes in, non-specific fever, and in a facility, even the best facilities where you don't suspect viral hemorrhagic fever, and everybody walking in the door, a whole lot of people got infected, including healthcare providers and medical students, and that's what exploded that outbreak. And I must tell you that if you want to see a model outbreak response, spend your time studying what happened in Rwanda for model outbreak response, starting with, for example, airport intake screening and outtake, entry and exit screening that was happening for Marburg disease immediately, quarantine, setting up a quarantine center right away. And then within that quarantine center, setting up various risk groups of, low risk, medium, high risk, what happens in those various areas to make sure you're making sure you're not moving virus from one area to the other, and within a specific area, minimizing transmission within the area. So lovely the way they had figured out how to do this and get people out and back home where they belong safely and well. And not to be surprised, it's Rwanda, and I'm not sure how many of those of you have worked in Rwanda or been to Rwanda, but the ministry did a brilliant job, including right away thinking about treatment of patients and healthcare workers. So completely on top of it. As I said, to me, I thought this was a model response from what I've said. And do I have another slide on? Oh, I'll show you this slide before making my point about the US. So how did these people, their work also included the vector work, right? Which is the most wonderful thing about these diseases. If I'm allowed to say something wonderful about viral hemorrhagic fevers, is that one health aspect of them, right? It's not just the human disease. If you want to think about prevention, you got to think about the environment, you got to think about animals, you got to think about how they sort of interlock and do cause disease in our communities. And so, likely bats contaminating, either directly infecting you or infecting directly infecting you by bites or feces or urine, and also contaminating food that you may eat. We see this with Nipah virus all the time. And in this outbreak, you'll see some slides on the side where they were looking at how long you could keep, this is an experimental model on the right with viral levels on bananas and mangoes. And so what people think is the bats may actually be coming early in the morning to get breakfast, pee on the fruit, and then the fruit remains infectious for about 6 hours or so. And the suggestion is that if you're going to get fruit off those trees, maybe do it in the afternoon and wash it first as a public health measure. So that's probably how this original case got infected there near the coal mines, or within the mine itself, obviously, if it wasn't from the fruit. And what you want to see is you want to see this. You want to see a limited number of cases, a limited number of deaths associated with those cases. And in this case, it took them 5 weeks. It took them 5 weeks, and they had this outbreak taken care of. And as I said, model response. They monitored 1,200 cases from this. Now, in the midst of this, so this was, again, an outbreak in one hospital, quarantine, other activities in another hospital, great surveillance going on, and all of a sudden, the U.S. was issuing a travel advisory for the whole country, right? This, of course, got some stern comments back from the African CDC and other partners to say, here's a country that's doing exactly the right thing, and we are penalizing them for doing exactly the right thing by telling us what's going on and managing it appropriately, right? You are not going to get ambushed by Marburg in the streets of Kigali, right? And I actually had to counsel some folks who were going to go do some gorilla watching there to say, you are going to be absolutely safe, but we need to be a little bit nuanced in some of these travel advisories we do. All right, I've got 15, do I have 15 minutes left, Kathy?
Yep.
Okay. If you have not figured out yet, I'm from Brooklyn. Okay. I speak very fast. I tried to probably put 100 slides in 60 minutes. So we're going to now speed up a little bit. Actually, to be honest with you, what I want to do is sort of clean up this conversation now. Taught you about viral hemorrhagic fevers, gave you some example of a recently really well done response in Africa, and chat about where we are globally around preparedness. So we've had the 10th year anniversary of the Ebola epidemic in West Africa, largest ever Ebola outbreak that occurred, 28,000 odd cases, 11,000 deaths. An original case was in Guinea, in some kid, probably again got infected by a bat, and then it spread rapidly in that Western Africa region to the contiguous countries. I've deployed there, I think I deployed there twice for a couple of months. That's a younger, more handsome version of me. And it was really the international collaboration, the support of the ministry. This was a well done response given the circumstances. Unfortunately, a very delayed response, and provided lots of opportunities to learn as we think about improving responses for the future, so that we all get to a point where our responses look like the Marburg response in Rwanda that are rapidly contained, and not an outbreak like this that spread to 3 countries. So fast forward 10 years, I I want to be honest here because I love talking about how great public health is. But the truth is that for all we did to save lives domestically and globally, the pandemic really did have a major negative global outbreak. And I think we need to be respectful of the fact that saving lives is really important and that needs to be a priority. But outbreaks are more than about the medical consequences. They're about the social, economic, and political consequences also. And if we don't do the saving lives job as well as we can, that exacerbates the social, economic, and political aspects. And so this is globally, we have our Healthy People 2030 goals. Globally, what you have is the Sustainable Development goals, and made significant progress towards the Sustainable Development goals. But unfortunately, okay, this is what the Sustainable Development, these are the 17 Sustainable Development Goals. Big chunk of 3 is us in health, but there's little pieces of health sprinkled into the other, clean water and sanitation. So there's little pieces of health sprinkled throughout these 17 goals. But what this COVID pandemic did was, let's see, can I read this to you? Oh yeah, by 2030 we're supposed to end all these epidemics. But what COVID-19 did actually is we saw a decrease in many of these markers, including throwing hundreds of millions of people back into poverty that weren't previously in poverty. So COVID-19 really was a significant issue of sort of retarding and leading to reductions in global goals. Another thing, so this is my quick synopsis, and I'm going to start this here and I'm going to finish it in 4 or 5 slides. So when I look at the outbreak, so I'm an old-timey public health person. If you haven't figured that out yet, right? And so when people, once upon a time when people said, Ali, what do you need to do to improve preparedness and response? I'd always start with EPI and lab, right? That's how I was trained. EPI and lab, improved EPI and lab. Well, I've learned better now. The number one thing we need to do is overcome distrust. We need to develop trust of public health, because for as brilliant as all of you, I'm sure, are on the call with great public health advice and suggestions, if people do not trust us as public health people, as professionals, it doesn't matter if we can give them good advice and what would save their lives. Right. And so we have to lead with trust. So this is a big concession for an old-timey public health person to tell you not to lead with good surveillance, but instead tell you to lead with good trust and help build resilient communities. The first time you are seen as a public health professional should not be when you tell people wear a mask and get vaccinated. You've already failed. I'll be very honest with you, right? They should know who you are and know since the day they were born who you are and what you do to improve health within communities. The other thing is the divide between health systems and public health has been way too long, and we need to sort of make sure that health systems are routinely incorporated in everything we think about and talk about public health. And you see this, this became very obvious during the response. The moment people die, the focus is on the people dying and no more on the prevention. So if you had that better sort of incorporation up front with sharing information and relationships, partnerships, how do you know how data is flowing? Makes things so much better during the outbreak. And then I'm going to give you number 4, reliable case identification and alert systems. And then after that, other things, emergency response, supply chains, et cetera, et cetera, et cetera, that needs to be done, all making sure that there's a sustained investment. So this would be sort of my sort of snapshot of what we should be doing, recognizing that we're only as strong as our weakest link. So Van Sui means long life in Chinese. It also means 10,000 years, which is about recorded history. So we've had this long history now with microbes, and that's just, let's be very honest with it, that's just not going away, right? Because the risk factors for the microbes are in place and continue to get worse, whether it's microbial adaptation or human susceptibility, our behaviors, our travel, changing ecosystems, climate change. I mean, all these things are going to continue to exacerbate these diseases because they sort of increase the interface between animals and humans for the most part, and change that environment to allow those spillover events to occur. And now that I'm no longer employed by the federal government, I'm allowed to say that the number one reason for pandemics is political inaction, and recognizing that there's other social and political and economic effects. So spillover is going to occur. It's a natural phenomenon. Outbreaks, epidemics, outbreaks, the original outbreak cluster, that's on public health, right? We need to be able to recognize those. We need to stop those. But when you start talking about a global pandemic, that is political inaction that allows something to spread globally or regionally. So I can at least be honest that the number one risk factor for pandemics is essentially bad policy. Bad politics. Are we ready for that next pandemic? Well, you can answer that question yourself, right? Was about 2-3 weeks ago, there was this mystery disease in Africa, 150 dead. Took a long time to figure out what that was. Fortunately, they figured out it was malaria. It wasn't the next pandemic, and hopefully there was some treatment given to people there. I had a potential deja vu moment when about 2 weeks ago, 3 weeks ago, there was reports of a new respiratory disease in China that was originally unknown, turned out to be human pneumovirus outbreaks. But another deja vu moment, like, oh, okay, is this now the next pandemic coming to us from China? And are we ready? No. More, yes, in some ways, no, in lots of other ways. And then, oh yeah, I think this was yesterday. So we may well have just seen the first cryptic human-to-human community transmission and human-to-human transmission of H5N1 in the United States with this child in San Francisco, I believe, who was diagnosed. They have no idea how this child got infected. I can talk about H5N1 later. I'm not sure it's such a big deal, but the point is, these events keep coming at us fast and furious, and we need to be thinking about how are we making sure we are prepared for that next pandemic. But let me end on some happy things. Global Health Security Agenda launched in 2014, a global effort to, and you can read it, increase global security engagement, et cetera, et cetera. 123 countries completing joint evaluations, 90 countries developing national action plans, and 58 countries meeting the target. So there is good news out there about how the global community is coming together to help support improved health security worldwide. Because a disease anywhere is a disease everywhere, and as we all know, we'd rather you take care of it somewhere else quickly than export it. USAID is helping strengthen infectious disease system activity globally. So that's a nice new project that's being supported in low and middle income countries. Internationally, WHO has taken the lead as a convener of a new international pathogen surveillance network. So taking advantage of some of our thinking about wastewater surveillance and various pathogen surveillance to help coalesce this international network of people doing this work, so there's more rapid identification of what's going on by looking at poop. And I'm also glad in questions and answers to talk about poop. Love poop. Okay, and the next piece of global work that's going on, unfortunately, we are the ones hindering a final new pandemic prevention preparedness accord. This was supposed to have gotten done next year. It's now being moved. It's what do they call, kick the can down another year. So we'll see if in May of this year there's an agreed upon new pandemic prevention preparedness and response accord. And then finally, we need you. We need you to help our communities recognize, as you do, that it's not just public health people and clinicians who are the health system. It's all of us collectively that are the health system. And how do we work together to maintain your mission in TEPHI, the safety of Nebraska, of Texans, and the economic viability of the community, and to make that case when medical freedom is the buzzword about we, right? Collectively, we. How do we take care of the collective, right? Which is why we came together as communities, because the we mattered. And the only way to get there is to help improve the trust that there is in public health. And I give some suggestions here about how to do that. I do want to go to this one, which is for a long time, I've told the second to last, for a long time, I've told my students and colleagues that I expect them to be good citizens working with their policymakers and politicians and decision makers to help educate them about public health, what we do, why we do it, how we save lives, how we ensure the safety of our communities, how we ensure a great workforce to remain a leader globally. But now I've changed my tune to say I also expect you to run for office. So of the 243 people left listening to this conference call with 3 minutes left, I'd like you personally to think about how can you run? And there's so many different offices to run for. I can have a whole lecture on that alone. But when I hear about some of the stuff that people say, our elected leaders say in the press, I go, oh my gosh, my students can do really well in this environment. So please consider yourself and be guardians of public health. And one that's missing from here is, I talk a lot about super spreaders. It's one of the mechanisms on how these diseases spread. But can you be super spreaders of not disease, but super spreaders of hope, right? I think that's for us. So let's work on the super spreaders of hope as public health practitioners and remind ourselves again of why we got into this business and how are we working to put the public back in public health. It's not just about the health, but also the public of the health between the great insights and science we bring to them, the great work we do every day in our communities, but all done with heart for our communities, because we are, it's not, we don't work, we are the community, right? We're of them, from them, by them. And I'm going to leave you with that. Oh, no, I guess I'm not. I guess I'm going to give you a QR code so you can get more of this. Thank you, everybody. And my
Yes,
apologies.
thank you so much. And I have a couple questions for you from the audience. And I don't know if you can see all the hands and hearts and celebration emojis that are on the screen for your talk. Thank you very much. Before I get to the questions, if you would like CPH credit, you need to fill out the evaluation form. Others who don't want credit, please still fill out the accreditation form. And I want to let you know about our March Grand Rounds. We're going to be talking about melioidosis. This is a rare bacterial infection that's emerging in the Americas. We have had a case in Texas. Dr. Tom Doker, who's a lieutenant colonel and public health officer in the U.S. Air Force, will be talking. So that information will be sent out shortly, but mark your calendars. Same time on March 19th. So some of these questions, let me go into the chat. I think you've touched on at least about what threats you're concerned with, the political environment and ability to prepare for and respond to future pandemics. Aren't we all scared about that? I don't know if you want to add anything else,
Sure.
Dr. Khan.
Glad to. So the threats I worry about, so the number one threat I worry about is influenza. It will always be the number one threat I will worry about. The second threat would be the coronaviruses. We know a rapidly spreading respiratory disease we know will with person-to-person transmission of high severity will always be a risk to us. Then the viral hemorrhagic fevers, obviously the ones I highlighted. We've seen how Ebola can cause very large regional outbreaks, and it's very easy to see how that could have continued to have expanded continent-wide. So those are some of the diseases that are on the top of my list for threats that I would be worried about. In terms of preparedness, I'm going to be honest with you. I'm of mixed mind here. So we are definitely more prepared today than we were 4 years ago during the COVID pandemic. Fortunately, during the Trump administration, mRNA technology was taken to scale, right? And so we now have a better platform to rapidly create vaccines than we've ever had before. Which is wonderful. So in that way, we are markedly better prepared. Our stockpiles are in a better position, et cetera, et cetera. I think communications across the federal government, some systems are better. So in that way, we're better prepared. But I think we're a lot less prepared in the trust that's necessary for community response to save people's lives. And that is really going to take the most work. If you look at the research, the countries that did best were the ones where the people had the most trust in their government. So I can't tackle the trust in my government. What I can tackle is the trust in me and my institution. And so that is something I think we need to do, is work on, is the trust in public health professionals. And you are lucky and blessed in many ways, because your work every day is to address the health needs and wellness needs of your community. So you're in a wonderful place to build that trust if you see that as a core responsibility for your work.
All right, and I know we're at time. I'm if you could answer this in just a
Sure.
couple of sentences, if possible,
Okay.
about how global health agendas include the US and Europe, because we have the resources. Lower and middle income countries may not receive support to work on them. How are these agendas created, accounting for those differences in resource availability?
And there'll always be difference in resource availability and inequity. We just need to accept that and see what we can do to help address that. But the Global Health Security Agenda, for example, is money for low and middle income countries for a core set of work that they do together with joint work plans. So that's to help improve what's happening in those countries. And then if you look at the Global Fund and a number of other pandemic funds, those are monies for low and middle income countries to help improve their preparedness for their own citizens. So it's not just about high income countries having lots of resources to do what they need to do. There really is a good collaborative effort. And kudos to the United States, to you, because we happen to be one of the most generous countries in the world in supporting the rest of the world.
All right, thank you. I'm sorry we couldn't get to the other questions.
My
Again,
apologies.
lots and lots of positive feedback from our participants. So thank you so much.
Thank you,
And
everybody, for the
everyone,
opportunity.
I hope we'll see you in March. And let me know or you can go on the TEPHI website if there are topics you want to hear about on these grand rounds. Thank you. Good evening.
Good evening.